We have gone through a topic that is heart failure earlier. Now we are going for the next topic, that is dysarrhythmias or arrhythmias, what we call it. What it is, what are various types into it, and what can be the treatment. We have already seen most of the things during pharmacology. We have classified. We'll just make a fast review of it and we'll go ahead. So what is dysrhythmia or arrhythmia? It is any abnormality of physiological rhythm, that is either it may be atrial, so we'll call it as atrial dysrhythm or atrial arrhythmias ventriculars. It is associated either location, which can significantly increase the morbidity and ventricular arrhythmias. The ventricular arrhythmias are life-threatening, and it has been found that the procedural treatment, like various treatments, which beta blockers, then calcium channel blockers and other agents, they are the most important treatments for the various dysrhythmias. And it has been, there is a little drug development, but several studies are giving some additional changes into it that we shall look into. So we are using various guidelines, and this is abstract of various guidelines. So bradyarrhythmias are what? Where the heart rate which goes below the normal range, which may be because of various reasons like sick sinus syndrome, atrioventricular AV block, or conduction disorders, and the heart rate is lower than normal range of 60 to 100 beats per minute. The National Institute of Health defines bradycardia as heart rate less than 60 beats in non-well trained athletes, because in athletes they can have heart rate lesser than that. But even if some people say that, or some guidelines make it that is 50 beats per minute can be taken it. So let us see and what are the ECG changes it can be making. So this sinus bradycardia, let us define. So these are various bradyarrhythmias. That is, we call it as a sick sinus syndrome, that is SN node dysfunction. So we call it as a sinus bradycardia where SN node firing rate which is less than 50 beats per minute. That we call it as a sinus pause. Sinus node depolarizes more than 3 seconds between the atrial depolarization and after most recent depolarization. There may be sinus node arrest, that is no depolarization taking place. There can be ectopic atrial bradycardias, that is atrial depolarization which is caused by an atrial pacemaker, which is other than that of SN node, and where the rate is, and this is more powerful than SN node. So rate is around less than 50 beats. There can be sinoatrial exit block, that is presence of blocked conduction between the SN node and the nearby atrial tissues. Therefore, whatsoever SN node, even though SN node is having more firing, it is not reaching to AV node, and we will call that blockade. There can be tachycardia, bradycardia syndromes. So because of sinus bradycardia, ectopic atrial bradycardia or sinus pause alternating with abdominal atrial tachycardia, atrial flutter or atrial fibrillation takes place. What happens in that is SN node is firing less, so other parallel ectopic focus, we have discussed it earlier. So that is form, and it causes additional this one. Then chronotropic incompetence, inability of body to appropriately increase the heart rate in response to increase in demand or activity. We have seen that during exercise. Sympathetic tone is there, fight or flight mechanism like situation wherein heart rate increases. So these are all related to SN node, or we call it as a sick sinus syndrome or sinus node dysfunction. Then other thing can be atrioventricular block, that is AV node is blocked. So we call it as a first degree of AV block, where P waves which are associated with these atrial contractions, and that will be changed, that will be modified. The second degree AV block, P waves with a constant rate, that is less than 100 beats per minute when atrioventricular conduction is present, but it is not 1:1. Then other are Mobis type, where the P waves are at the constant rate, again less than 100 beats per minute. And periodic single non-conduction P wave is associated with P wave before and after the non-conducted P wave. So these are various ways which are detected using these ECGs. What are the various conditions which are responsible for bradycardia? It can be because of the autonomous disturbances like carotid sinus hypersensitivity. What is importance of carotid sinus? You have studied it in physiology that it is having baroreceptor. So baroreceptor will be sensed, even small pressure will be sensed as a high pressure. Just a minute. So these are various disturbances like carotid sinus hypersensitivity. Because of that baroreceptors more sensing blood pressure. Because of more sensing blood pressure, it will be causing decrease in the sympathetic outflow from the cardiovascular center, and thus it will decrease the heart rate. Then neurally mediated syncope or pre-syncope. Syncope means because of the decrease of in the activity of central system. There is a syncope is sort of decrease in the blood supply, and because of that there is a reduction in the activities. Then next is the physical conditioning. Then situational syncope, that is because of the cough, defecation, glottis stimulation, medical procedures, vomiting. Because of that there is a decrease in the blood supply. Sleep or without without sleep apnea, which causes decrease in the these activities. Then metabolic changes are there. Metabolic acidosis, that means the pH of the blood that goes decreasing than normal. It becomes comparatively more acidic. Then hyperkalemia, that is increase in this potassium. Then hypokalemia, hypothermia, hypothyroidism, hypoxia. These are various conditions which are there. Then next is cardiomyopathy. Ischemic or non-ischemic myopathy is there. We have seen myopathy during heart failure. That is because of whatsoever reason there is a myopathy, and because of that there is a decrease in the pumping. Then it can be congenital heart diseases which are having lesser heart rate, degenerative fibrosis, infection, inflammation, Chagas disease, diphtheria, infectious endocarditis. These are various infections. Lyme disease, myocarditis, sarcoiditis, toxoplasmosis. These are various infections which are causing. Then next is ischemia infarction, that is affecting the arteries or ventricles. Then rheumatoid diseases like rheumatoid arthritis, then scleroderma, systemic lupus erythematosus. These are all autoimmune disorders which are affecting. Then surgical or procedural trauma, that cardiac procedure like ablation or cardiac catheterization. Then congenital heart disease surgery. Then septal myectomy for hypertrophic obstructive cardiomyopathy, or valve surgery. These are various conditions in which there can be bradycardia. Now what we shall be doing for that? What shall be the treatment available? Any other medications, whether they are available, which medicines can cause decrease in heart rate. If you know, if you remember, or if you can immediately revise it out, you can check your own knowledge. I will not take time. Those who are interested can immediately start writing in that. This is for checking your knowledge. Those who do not want, okay, cholinergic, very good. Then very good, Aniruddha. Then all anti-adrenergic agent. So let us see these drugs. Adenosines, amiodarone. Amiodarone we have seen as a anti-arrhythmic agent while studying in pharmacology. All beta blockers, including eye drops, clonidine, digoxin. I told you digoxin is a very interesting one. It can reduce heart rate in the arteries, and it can increase heart rate in ventricles. Then others are flecainide, ivabradine, methyl dopa. Already flecainide we have discussed it in what we call it as a antiarrhythmic agents: procainamide, propanofen, trazepin, quinidine, sotalol. Sotalol is a beta blocker that way. Then ticagrelor, this is anti-ischemic agents. Then donepezil, lithium, opioid analgesic, phenothiazine, phenytoin. Phenytoin is also not only anti-epileptic, but it is also there as a anti-arrhythmatic agent, class 1A drug, if you remember. Then selective serotonin uptake inhibitors, tricyclic antidepressants, and there are certain these herbal supplements in that lobelia, if you just like he was telling. So lobelia is having that particular activity because it is acting on cholinergic activity. It is having lobelin, which is cholinergic in nature, and there are such many agents which are acting. Squil is also having cardiac glycosides and other medicals. So these medicines, they may cause decrease in heart rate, and what we can do in that, what should be the treatment which, when there is acute bradycardia, when there is a sudden bradycardia, then what we will be doing? Check the patient's stability while simultaneously evaluating and for initiating treatment, because you don't have much time. You have to treat it, because if the heart rate falls too much, then definitely cardiac output falls. Cardiac output falls means less blood supply is available for all body, including vital organs, and because of that, if it is less, then it can affect organs. So bradycardia can be dangerous one. So go for that, evaluate it, and go for various treatment. If it is a mild symptom are mild, evaluate and observe it. If moderate to severe symptom, immediately administer atropine, which is anticholinergic in nature. If there are severe symptoms and the person is hemodynamically unstable, begin acute pacing. Intravenous beta agonist can be considered. We call them as a inotropic agent, if you remember. So these are all positive inotropic agent. Example of these are epinephrine, it can be, then dopamine, dobutamine. There are a variety of such agent which increases the heart rate. We have already seen them as a in heart failure, that which are known as a cardiac pacers, or which causes increase in the cardiac activity, which increases the rate of heart. So these agents are there. So intravenous beta agonist may be considered if pacing methods are not immediately available. Avoid the beta agonist and expedite acute pacing in patient if pacing is available. Pacing is cardiac pacing devices are there, and the expedite acute pacing in patient with acute bradycardia caused by myocardial ischemia. Usually many patients die because of this only, because all of a sudden the heart rate goes so down. If the patient is hemodynamically unstable, then administer atropine and begin acute pacing. Intravenous beta agonist may be considered if pacing methods are not immediately available. Same, avoid beta agonist. If pacing methods are available, then preferably go for this pacing one, and expedite acute pacing in patients which are having this myocardial ischemia. So what are various drugs which are available for this? Example of this, the drugs which are available, let us have so aminophylline is one agent. We have seen aminophylline earlier in respiratory, we have seen it. It increases, or it is a phosphodiesterase inhibitor, and because of that it causes activity. How it is there? It inhibits the suppressive effects of adenosine on the SA node, and thus it can be useful in that. Atropine, atropine is an anticholinergic agent. It blocks acetylcholine and the muscarinic receptors, and it leads to increase in the cardiac output. So this is another agent. Dopamine, dobutamine, already we have discussed. Dopamine is acting on beta 1 receptors and also dopaminergic receptors, and thus it increases heart rate. Then calcium chloride or calcium gluconate can be given. We have seen calcium channel blocker, which decreases heart rate or force of contraction, okay, because they are stopping calcium for doing this all depolarization and contractions. Here we are giving calcium, so which should increase the calcium entry into the myocardium, and thus it will increase the rate and contraction. Then digoxin specific antibody fragments, it can be given particularly for acute toxicity of digoxin. If it is there, there for digoxin, then only it is useful, otherwise not. Epinephrine is again a beta agonist which can be used. So these drugs has to be considered. Normally aminophylline is well tolerated. Dose is utilized which is less than typical loading dose, and minimal data to support use, or data is not sufficient. It can exacerbate pre-existing anticholinergic symptoms, is a problem with the atropine. This dopamine is readily available, and it is always usually in most of the hospital it is available. Reserve calcium chloride for the central administration to avoid the extra vessation, because it can otherwise go into other tissues. If it is given by intramuscular route, then it can be a problem. So intravenous is a better one. These antibodies are of very high cost, but then there is no other alternative also, and these are administered if the person is intoxicated with digoxin. Epinephrine is a very common one, and they use it at continuous infection in infusion instead of single IV drug during cardiac activities. Then next are glucagon, high dose insulin therapy, and intralipid emulsions. So these are various other activities. If glucagon is given, it causes increased cardiac cycle adenosine monophosphate enhancing inotropy. So it improves because of from glucagon this metabolism will be there, and increase the cardiac cyclic adenosine monophosphate enhancing inotropy and chronotropy. It has got increased risk of aspiration in patients with decreased mental status. In that it should not be given. High dose insulin therapy is given. The mechanism is it enhances the carbohydrate use and energy production by myocardial cell, resulting into improved contractility. This is one of the important therapy, particularly after myocardial infarction, when the person survives from that, and to avoid the next complication, usually high dose of insulin is given. We call it as a GIK. The more glucose, more insulin, and more potassiums are given, and thus the heart, which is weakly pumping, it can start or it gets some energy to do it, and if that particular energy is regained, or it can start, then person may survive for some year at least. This is what the possibility is there. Then intralipid emulsion injections, these are having these lipids are there. It is not clear how exactly it is acting, but it is believed that this lipid sink theory is there. The lipophilic molecular partition into lipid plasma compartment, and it become unavailable to the tissue. It causes direct action of the myocardial calcium channels, and it utilizes fatty acid as an energy source. Fatty acid is better source than glucose source, but many times that during ischemia there is a changes in the metabolism sources. So these are the problem. What are the problem or this ADRs are associated with? These are fat embolism. It causes interference with the lab analysis because of the lipemic blood. Most useful in the lipophilic drug overdoses like propranolol, diltiazem, or verapamil, so that these drugs which have reduced the heart rate, this will be taken up, and it is used in that particular cases where we have to take out or suck back all these drugs rapidly. Then next in that is whenever there is a drug toxicity suspected or present in these people, then priority is to establish perfusion. Particularly, already we have seen in myocardial infarction, when perfusion is lost, then what we shall be doing. So first is perfusion has to be established, and some of the following treatment may not be readily available in the emergency. Then accordingly go for that. Go for check out what are the reason, whether there is a drug toxicity for bradycardia, whether it is a toxicity of beta blocker, whether it is toxicity of calcium channel blocker, whether it is toxicity of digoxin. If it is beta blocker, then go for IV glucagon. If it is calcium channel, then go for IV calcium. If it is digoxin toxicity, then go for anti-digoxin antibodies. Then along that, after glucagon, give high dose of insulin to balance the metabolism and to make it available. Then next is in calcium channel blocker, also give a high dose of insulin so that more energy is available, more glucose is available. And you can give intra-lipid emulsion in both cases, particularly if these agents which are having high lipid solubility are administered. So for that, this particular algorithm is used in various toxicities which has resulted into bradycardia. Then next is other type of arrhythmias. So we have got two ways in treatment. Let us summarize. We have got two things. If it is drug induced bradycardia, then try to see how we can avoid it, how we can recover from that drug toxicity. And if it is because of certain medical conditions like ischemia or some other condition or genetically, then can we make a pacer activity, can we improve the pacer activity, or if not, then we have to give the drugs which are beta 1 agonist, and by that virtue they will be increasing the heart rate. So our cardiotonic drugs or cardiac, what we can say, the agents which are having this inotropic agent, we call them. So these inotropic agents, positive inotropic drugs are given in that. Now second are the cases that is to what we call as a supraventricular arrhythmias. There are many types of it. Supraventricular arrhythmias. Supra means above, ventricular. So the arrhythmias which has got origin or which are generated above the ventricles, we call them as a supraventricular arrhythmias. Usually these are tachycardias, so we call them as a supraventricular tachycardias. So most of we shall see there are so many varieties of that, and what are the problems which are associated with this. So what are these? Example of these are atrial tachycardias. So first one is focal atrial tachycardias. So this supraventricular is arising from the focal atrial side. There is some focus, just like sinus node. There is another focus, or we call it as a ectopic focus. So because of that, there is a focus, and that is causing the activity. Then in that there are regular discrete P waves are there. Often isoelectric segment between P wave is there. Then second one is multifocal. There that is more than one such ectopic focus are present, and which are resulting into atrial activations in different rates at different places. So what we can get in ECG, we will get different kind of P waves into this. And what is the difference between single focal and multifocal? So in that there is a regular but discrete P waves will be there, and there will be isoelectric. Isoelectric means similar segment without much change. However, here the segments will be changing in multifocal. Atrial flutter, we already seen what it is. It is involving a circuit that rotates around the tricuspid wall in a counterwise direction, and these flutters are there, which causes increase in the atrial rate. It can be typical or atypical. When typical is there, it rotates around the tricuspid wall. If it is atypical, then there is a re-entrant phenomenon that is not dependent on conduction through the tricuspid isthmus. And what can be the reason, or what are the specificity? These are typical are characterized by predominantly negative flutter waves in the inferior leads. They are called as a sawtooth waves in the ECGs, while the atypical can be idiopathic. Idiopathic means of which reason is not known, and they are commonly occurring in the patient with the atrial scarring from the patient's heart surgery or ablation. Ablation is a heart treatment, a surgical treatment which is taken place in the heart, or what we can say interventional treatment rather. So AVNRT is this re-entrant pathway which is involving two distinct fast and slow pathways. We have seen re-entry, that one path is blocked because of ischemia. Earlier there were some ischemia. Then the impulses are coming to this. They cannot cross behind. We have seen gap junction earlier. They cannot cross it. Then they will come there and they will come back. So coming back from that, that is called as a re-entrant pathway. So again it will come back into same tissue which was not supposed to come. So this is what re-entrant pathway. Then atypical is there, this re-entrant is there, accessory pathways are there. There are extranodal AV pathway, that is apart from AV node, SA node to AV node, there is another pathway, additional pathway is there that connects atrium to ventricle, and therefore additional pathway is there. So if it is manifest accessory pathway that contains anterorogrally, so if it is there, then this means opposite way, and concealed pathway is there that is conducted by retrogradely. So these are different ways. This is in one direction, is another direction, and one is very common one, that is called as a WPW, that is old Parkinson White syndrome. It shows that there is a supraventricular tachycardia or supraventricular symptoms with ventricular pre-excitation during sinus rhythm. So ventricular gets excited before it receives the impulses from AV node. So this type of activities are there, which are important, and they are responsible for AV arrhythmias. Now what are the treatments for that? Usually we say that digitalis can decrease the rate digitalis is used in these atria. Then we can use any type of sodium channel blockers which can cause it, and beta blockers which can reduce it. Depending on the sign we can do it, is one thing important. And another thing is, here in that we shall see that we have to give, in addition to that, we have to add the treatment for the anticoagulation. Again I'll remind you, we have seen it, that whenever there is atrial flutter particularly, or atrial arrhythmias, so on the atrias, near atrias, on the atrias rather, there are appendages. We call these appendages as auricles. So these auricles are there, in auricle blood is there, and because of the atrial contraction relaxation, these auricles are getting contract and relaxed, and because of the contraction relaxation, blood circulation is maintained. But when the atrias are having arrhythmias, they are so rapid that the auricles do not face the these wavy contractions or powerful contraction and relaxations. Then these auricles, the blood which is in the auricle, that becomes stagnant for some time. Because of that, it can form blood clots. Because of these blood clots which are coming, this can sometime get escape from that, it can come to heart, and from heart it can go to circulation. Now wherever it will go, that is wherever this clot will go, that can cause problem. Usually most of time it goes to brain, it causes stroke, or it can go to heart, it can cause heart attacks, and therefore it is very dangerous. So simultaneously, during atrial arrhythmias, during atrial increase in the rate, although it has no role in arrhythmia, these are used only for the treatment, that is, or for the prevention of the this occlusion of or blocking of the arteries. So these are various reasons which are occurring over there. Example of these are, let us see what are supraventricular tachycardia management arrhythmia. So these are regular supraventricular tachycardia is there. So let us go for how we can improve the vagal maneuvers or intravenous adenosine. Adenosine is a drug of choice in this. If it is ineffective, if adenosine is not working or it is not reasonable, then check whether patient is hemodynamically stable or no. If hemodynamically stable, then go intravenous diltiazem or verapamil or beta blocker. Diltiazem, verapamil are calcium channel blockers, and beta blocker, you know what it is. If not, then go for this direct DC cardioversion. DC cardioversion means electric shock which is given, and this electric shock is maintaining the what we can say, electrical conduction in particular way. So that is first treatment or immediate treatment for that is the synchronized DCCV, that is what I told you, it as a DC current there cardioversion. So this DC cardioversion is one of the most important treatment, or it becomes a first line treatment in the acute this acute fibrillation, atrial fibrillation or acute flutters in the form of synchronized DC cardioversion for both symptoms, that is for resolution and prevention of the tachycardia mediated cardiomyopathy. So these are very immediate one, but if it is not available, then go for the calcium channel blocker or beta blockers. These are the best one. Then other one are in flutter, all these treatment we are going for. So if it is not there, then go for ibulide, which is successfully converting atrial flutters into 60% of the cases, and concurrent therapy with intravenous magnesium can also increase the efficacy of this ibutylite and reduce the incidences of Torsades D points. It is again one of the what we say, ventricular tachyarrhythmias. So these are various tachyarrhythmias we are treating. Similar to ibutylite, there is another, its congener is there. Dofetilide can also be used for the this conversion and maintenance of sinus rhythm in hospitalized patients who are clinically stable. Amiodarone is reserved. Amiodarone has a problem that it is highly enriched in iodine, and therefore it can cause iodine toxicities. It should be reserved for the patient with heart failure or those who have refractory to the other agents, because and therefore this high amount of iodine which is present, it can cause so many iodine related side effects, and therefore it should be used as a last resort. Then atrial fibrillation is there, it can be treated with various agents. Let us see what are various agents which we can using. So for again the treatments are adenosine, various beta blockers like esmolol, metoprolol, propranolol, then non-dihydropyridine calcium channel blockers. Which are these? Non-dihydropyridine. What are dihydropyridine calcium channel blocker? Which are dihydropyridine calcium channel blockers? Very good. What are dihydropyridine? So example of non-dihydropyridine are diltiazem, verapamil. They are preferred because they have more calcium, more selectivity to the cardiac tissue than compared to dihydropyridine, which has got more selectivity towards blood vessels. Then cardiac glycosides, we have seen digoxin, and it causes direct suppression of AV node conduction, and it causes increased effective refractory period and increases the conduction velocity. So that is the problem. Then other drugs like flecainamide can be used. We have seen all these antiarrhythmic agents, procainamide, propafenone, these are all used against various arrhythmias. Then class 3 antiarrhythmic agents are amiodarone, dofetilide, ibutylite, sotalol. These are various agents which we consider in the class 3. And this is a brief pharmacology of each drug is given. We have already studied it as a pharmacology, so we will not go for detailed pharmacology of it. I told you about how the anticoagulants are important, particularly in atrial flutter or atrial fibrillation, and very important. These are various drugs which shall be going through actually later. These are various agents like enoxaparin, heparin, then factor 10A inhibitors. These are called as a apixaban, then endoxaban, then rivaroxaban, then digitra. These are agents which are there, and very important that these treatments shall simultaneously be done. Or usually in Indian cases we give warfarin or such anticoagulant agents so that coagulation do not take place, and because of that this coagulation will not form the thrombus, and it do not cause occlusion of various blood vessels, resulting into very severe or very complex activities. So these are the anticoagulation agents which are added into the treatment. Now, what are the ventricular tachycardias? And there are changes in the pulses. So these are we can have again variety of such agents wherever we can make the treatments for that particular drugs. These are left ventricular diseases which are associated with the ventricular arrhythmias or tachycardias with changes in the pulse, and these are because of the relative electrophysical instability status after implantation of these various devices which are installed. We call them as a left ventricular assist devices. So left ventricular assist devices are doing this LVADs. These are left ventricular assist devices, and these are doing this electrophysical instability status after post implantation, and they can cause ventricular arrhythmia. They are the most common in the immediate post operative period, and they are generally decreased in the frequency during the subsequent weeks, month. So for that what we can do is various treatments are given into it, or some observation is done for that, so that we can monitor, we can check it, and this treatment are done with the like beta blockers are first, then amiodaran, and they are used in that. The optimal, or it can also be used with the cardioversion. Cardioversion is what I told you, DC that is DC is a direct current, and cardioversion means the arrhythmias are reversed or worse. So this is a DC cardioversion is one of the technique which is there. These are used for the treatment of this ventricular tachycardia which are having this pulse, and these are the LVDAs are there, that is left ventricular assist devices are there. These are actually put into patients. These devices are put into patients which are having the heart rate problem or conduction problems, and to make it in a clear way, you can put it in Google, or I will try to show you. This will have sort of continuous impulse which is going to heart. We call them as a artificial pacemakers. So these are the artificial pacemakers, and these are giving pace. They are monitoring the pace to the heart through this. So this is how this pacemaker is having initial problem of increase in the heart rate, and which can be monitored, which can be done with the pharmacotherapy with beta blocker or some of the calcium channel blocker. So this is how the various agents which are there. We shall see them again in detailed guideline wise. I'll just change it and I'll show you how the guidelines are there. See, these are how the guidelines are. This is the latest guideline which is available, which may not be present in book because the book copies are older one. So this is the latest guideline, that is 2017 AHA, that is American Heart Association, then ACC, American College of Cardiology, and heart research groups. These are having guidelines for management of patient with ventricular arrhythmias and prevention of sudden cardiac death. Sudden cardiac death is one of the biggest problem because of the arrhythmias are there, because too much heart rate can result into sudden stoppage of heart. So these things are there, and for these things there are guidelines. According to guidelines, there are various treatments which are suggested. We shall go very fast into this. The details are there, how these guidelines are made, then how this is already you have studied it. I will not repeat this, because this is how the evidences are there, that is we call it as a class of recommendation and level of evidences. That is how the class of recommendation is. The class of recommendation is always strong when benefit is more than risk. It is slightly moderate, we call it as a class 2, that the strength or of that. Then where benefit and risk has a problem. So this is everywhere, whatsoever drug we are selecting, maybe as I told you, in various diseases made by arrhythmia, so many drugs we have seen. We have seen, if you remember, you have seen it as a Vaughan-Williams classification, class 1, class 2, or class 1, class 1A, class 1A, class 1B, class 1C, then class 2, class 3, class 4, and some additional drugs. So this is all various classes you have seen. Now here, from that, which drug is better in what condition? There may be again varieties of arrhythmias are there. Some are atrial, some are ventricular. Again, in that the reasons are different. So we cannot have very clear thing that any kind of antiarrhythmic can work for any kind of arrhythmia. So we have to have a study. Our study will, and that study will guide us which drug should be used in what condition. So here we have got various class of recommendation, we call it as a COR, class of recommendation, and second criteria we have got is a level or quality of evidence, and we have discussed it earlier. These colors are very common in most of the guidelines. These colors are very fixed. Green color means where benefits are more than risk, the too much benefits are there, and that is absolutely best thing. Then second thing is it is moderate one. Benefit to risk is comparatively lesser benefit than the previous one, but still the benefits are more than risk. Then class 3 is having weak one, that is benefit are almost equal or slightly greater than risk, and class 3 there are no benefit. Okay, they are moderate, benefits are almost equal to risk. Usually we do not recommend until and unless there is some typical emergency. And class 3 again, last one is risk are more than benefit. It is absolutely no, there is no importance of that. Then level A we have got, that is where there is a high quality is there. Then level BR means this is level B is there with randomized studies are there. Level B again we have got group, that is level B with non-randomized studies. Third one is there, that is level C with the limited data, and level C again we have got one more, that is level C with limited data, level C with expert opinion. So these are only A, B, C are the level. Level A is having, there are so many trials are there, that is more than one trial is there. and all the trials are high quality. So this is all we have discussed earlier. You please remember this, and on that basis the guidelines are made, and on that basis the type of drug which is recommended, that is first line treatment, second line treatment, third line treatment, they are maintained. The drug which is very effective, which is found in level A type of level of evidences, which is found and which is found safe in all this is the most important drug, or it is the first line drug. And as the level or the class of recommendation goes down, that is if it becomes class 2 or level B or whatsoever, then accordingly it can become second choice or third choice. So this is the first choice or first line treatment, second line treatment. So on that basis these treatments are there. They are determined independently. Then these are because COIR are done separately or simultaneous, or LOE is done differently, and then they are mixed, and accordingly where both are good one, where both are having good, then we go for this. So we shall see about this type of details about this what we can say guidelines and algorithms in our next class. I expect by that time you please go through your revision of anti-arrhythmic agents and basics of cardiovascular agents, so that it will be helping you. We'll revise this in next, we'll go for actually use of this what we say, this type of guidelines which are there, which are published by important organizations, and we'll use them as a how these guidelines are there, what these guidelines are suggesting. So there are variety of important guidelines, and then on the basis of guidelines the treatment shall be made. So if you have any doubt, you can ask. You please refer guidelines when you are using therapeutics, and for pharmacology you use your pharmacology books, which will help you to understand the topic well with mechanism of actions and their limitations. You can use in that way. So take care and be cautious.